Hello, everyone. Welcome to today's CAP Echo. It's wonderful to have you each here today. And today we're going to be talking about anxiety. And it's just like, as we're coming in, just want everybody to briefly type into the chat your name, what county you practice in, and then also just like one thing that you like to do to reduce your own stress. And so let's go ahead and advance the slide just by one. So go ahead, type in your name, what county you practice in, and your favorite stress buster. And for me, I'm Joanne Jung. I practice in San Francisco. And my personal favorite stress buster is nature. I love just like hiking out in nature, mountains and lakes, forests, redwoods, all prefer it. So very happy here in Northern California. So please go ahead and type in your stress buster. And let's go ahead and move into announcements. It's great if you can keep your camera on. We recognize this is the lunch hour. We don't mind if you eat on camera, please do. We'd love to see you. This is a community where we're all coming in to learn and to share together. This is all teach, all learn. And so please, if you can, keep your camera on. Good to see you. And as usual, we will be recording today's didactic presentation. And that recording, after a little editing, will be posted to our CAP website, usually within a week or so. And normally we don't record our case discussions, but today we are asking permission, if we can, to record today's case discussion only. And I'll let one of our speakers, Dr. Swan, describe like what purpose this will serve.
Hi, so I am applying for psychology board certification, which is sort of the psychology equivalent of what a lot of you did for your board certification. And part of this requires submitting some recorded practice samples, and one of them is around consultation, and was hoping that I could use this as an example. That particular sort of case discussion would be sent only to my board examiners in a secure platform that would then be erased as soon as they finish reviewing it. Of course, the focus is on me. So if you would be open to having the case discussion recorded, so I could use that for my board examination, I would certainly appreciate it, but also no worries if not, that's completely fine too. And I think if you are sort of not wanting that to be recorded, you can send a note to Joanne.
Wonderful. Yeah, so just message me privately if this is not okay, and I'll let the group know if this is or not a go. And as usual, a big part of how we teach in ECHO really is revolving around this case discussion. And if you have a particular burning desire to like present a case on depression, for our next ECHO in September, please email me afterwards and let me know. And with that, let's go ahead and move on. And I'd like to go ahead and do a more official introduction for our guest speakers today. Dr. Anna Swan, you just heard from a minute ago, is a licensed clinical psychologist who specializes in working with children, teens, and families with anxiety and related concerns. She is a California clinical director of Lumate Health, which is a telehealth company that specializes in providing cognitive behavioral therapy, or CBT, for teens with anxiety and OCD. So Dr. Swan was previously on faculty here at UCSF, and before that was at NYU. She continues to provide training and supervision in her areas of expertise. And Dr. Lauren Schumacher is assistant clinical professor of psychiatry here at the UCSF School of Medicine. She is a child and adolescent psychiatrist in the Division of Mental Health and Child Development here at UCSF, Benioff Children's Hospital as well. In addition to serving on our CAP line as a consultant, she also provides clinical care in our outpatient clinics here at UCSF. On both sides of the bay, both in San Francisco and in Oakland. And with that, I'll turn the virtual mic over to the two of them to give our talk today on anxiety.
Thank you. So I have some reported stock disclosures in my position through Lumate Health, and then CAP is supported by federal, state, and grant funding. So our aim today is to have you come away feeling comfortable identifying and diagnosing anxiety disorders in primary care, having an understanding of how to explain cognitive and behavioral strategies to help youth with anxiety, and then also to think through when to consider medication for anxiety. So we wanted to start with some information about youth mental health within the context of this COVID-19 pandemic that we've all been living with. So 2.6 billion youth across the globe were affected, with 1.5 youth in 193 countries being affected by school closures. And in a recent meta-analysis of sort of across the world, the prevalence rates of both depression and anxiety were demonstrated to have doubled compared to pre-pandemic estimates. So if you're sort of seeing more concerns around anxiety and depression in your primary care clinics within the wake of the pandemic, you are definitely not alone. And this has led to the US Preventative Task Force recommending starting to screen for anxiety at age 8 in response to this ongoing youth mental health crisis. Next slide. So we're going to start with, what is anxiety? Anxiety is a human emotion that we all get to experience. And there are 3 components to it. There's the feelings piece. So when we're thinking about anxiety, you're considering that fight, flight, freeze response. Then there's the cognitive piece. So usually when we're nervous, we're thinking ahead to bad things that might happen. And there's also the behavioral urge that comes along with anxiety. It's an uncomfortable feeling, and it often leads us to want to escape or avoid the situation that we're feeling nervous about. And often anxiety can be quite healthy. So imagine I have a test coming up. I'm feeling a little bit of butterflies in my stomach. I'm thinking, I don't feel like I know everything that I need to know. And that might inspire, motivate me to study a little bit more or ask a friend for some help. Healthy anxiety. Now we can imagine that same situation where maybe instead I'm feeling nauseous. I think I'm feeling like I'm going to throw up. I can't concentrate. My muscles are tense. I'm thinking that I don't know anything in this subject. I'm going to fail. It's going to wreck my grade. I'm not going to be able to get into the college that I want to, have the future that I want, sort of going into that anxiety spiral. And then I'm so overwhelmed that I procrastinate. I can't bring myself to study. And then maybe I even miss school the next day because I'm so nervous about this test. And so their anxiety has gone from being healthy levels to being louder, more intense, more problematic. And we often think of this as a false alarm. So when I'm talking to families about this, I'll use the analogy of a car alarm. Think about how many times have you heard a car alarm go off in your life? And then think through how many times have you actually seen someone breaking into a car? And so what's often happening is anxiety is setting off this alarm, saying that we're in danger, but actually it's a false alarm. It's sort of a broken smoke detector. And when we're thinking about sort of when is problematic anxiety meeting criteria for an anxiety disorder, you can consider the 4 Ds. So the first D is dysfunction. And this, I often think of this as one of the more meaningful things to consider. You're wondering about, is this anxiety holding the child or the teen back from what they want to do and what they need to do with their family, in school, with their friends, with extracurricular activities? Is it causing significant impairment? The second is distress. So again, anxiety is an uncomfortable feeling to have. And when it's chronic, when that alarm is going off often and intensely, it can lead to significant upset. The third is duration. So we're all heading into the school year. It's really common for youth and parents to feel some elevated anxiety around transition points, first week, first month of school. But when anxiety has been going on for an extended period of time, 6 months or longer, that indicates that it's not going to go away on its own. And then the fourth is deviation from the developmental trajectory. So you're thinking about, is this anxiety more than what we would expect given where the youth is in development? And then also for youth who have had anxiety for an extended period of time, we can see how that experience can actually hold them back from meeting certain milestones. So they might miss out on that first sleepover. They miss out on going to camp. Maybe they don't try out for that sport or that club. Maybe they don't learn how to drive. And then maybe that extends into difficulty launching into adulthood. Next slide. So here are some quick facts. Anxiety disorders are incredibly common. 3 in 10 youth will meet criteria for an anxiety disorder by age 18. At the same time, they're often overlooked. Many times youth with anxiety are not having behavioral difficulties at school or at home. They might be that straight A student. And so it just doesn't get picked up. And at the same time, it does cause significant distress and significant negative impact in academics, social, and family functioning. We also know that anxiety disorders don't tend to go, sort of a watch and wait approach isn't appropriate. And in fact, without treatment, anxiety disorders tend to persist into adulthood. And we often think about this as a gateway disorder, where the presence of an untreated anxiety disorder can lead to more problems over time, like developing additional anxiety disorders, depression, substance use. You might think about that middle schooler who has fears about social situations. They have a hard time making friends. That really sets the stage for more depressed mood in high school. And then maybe they turn to using substances as a way to cope with those negative emotions in an unhealthy way. And so that's why we're all here, because primary care is such a fantastic setting to increase both the identification and the treatment of anxiety disorders, because it's incredibly common and it's also quite treatable. So we're really excited to share more today. Next slide. So here we have some quick overview of the different types of anxiety disorders. The main thing I want to highlight is that comorbidity is the rule rather than the exception. It's incredibly common for youth with anxiety to meet criteria for more than one anxiety disorder at the same time, or for the flavor of their anxiety to change over the course of development. And here I'll highlight a couple of the really common ones that we see. The separation anxiety, we see this more in younger kids, but you can see it in teens. Here, youth have a difficult time being away from parents. You might see distress, sometimes physical symptoms like stomach aches, headaches around separation for school, play dates at nighttime. And the core fear is that something bad is going to happen to the kid or to their parents when they're separated, like the parent might leave and never come back, or the kid might get kidnapped. Generalized anxiety, here the key feature is worry. That's what you're listening for. And these are excessive worries that the youth is really getting stuck in. They're hard to control. And oftentimes it might just be flavor of the day worries. Today I'm worrying about school, tomorrow I'm worrying about safety, but there's always something to be worrying about. And again, you see those physical symptoms: trouble sleeping, fatigue, muscle tension, irritability, and difficulty concentrating. Social anxiety, the key feature here is worry about others' judgment, fears about being laughed at or embarrassed in social situations. And this comes in two categories. Sometimes it's performance-related situations like class participation, presentations, and sometimes it's in less structured social situations like starting conversations, going to parties, assertiveness. Often it's in both. Panic disorder, the main thing to be listening for here are panic attacks that are untriggered. So the youth is not in a scary situation, they're not having worry thoughts, but suddenly out of the blue, they get this rush of panic symptoms, and that leads to related worries about it happening again and distress. And then the last one I'm highlighting here is obsessive compulsive disorder, though technically not an anxiety disorder in the DSM anymore. It's very, very similar, and our treatment is pretty similar too. So here it's characterized by intrusive thoughts that can come in lots of different categories, and then related compulsions or rituals aimed to mitigate the distress associated with those thoughts. But then those rituals actually serve to sort of feed the OCD cycle over time. Next slide.
So it often can be very helpful to use an assessment tool to try to help sort out kind of what different anxiety pieces might be going on. I especially like using the SCARED, which it's research validated for ages 8 to 18, but we also sometimes use it for ages a little bit younger than that as well. A nice thing about the SCARED is that it has both a self and parent report. And it assesses for kind of overall anxiety, as well as some of the individual disorders like generalized anxiety, separation anxiety, panic, social, and school anxiety. The main downside is it's a fairly long survey, that it can be really helpful if you're able to kind of give it to the parent and kid and maybe have them fill it out between visits and bring it back. It can give you a lot of helpful information. I also like using the GAD-7. That one looks specifically at generalized anxiety. This one's validated for ages 13 plus, and it's just a self-report. But a nice thing about this one is it can be good for helping initially assess anxiety, and also can be great for kind of tracking response to treatment over time. And is a shorter one, so easier to have the youth do more than once. And both these are available on the CAP website. Next slide. So the good news is that while anxiety is on the rise, we do have effective treatments for it. And the ACAP practice parameters recommend both SSRIs and psychosocial treatments as being an important part of treating youth with anxiety disorders. Next slide.
So I'm going to share a little more about cognitive behavioral therapy, or CBT, which is the treatment for youth anxiety disorders that has the most empirical support behind it as being an effective treatment. And there are three components to CBT that sort of map onto those three parts of anxiety that we were talking about earlier. And then the other thing to know about CBT is that it's a time-limited and goal-oriented treatment. So the goal is really for the youth and their family to learn to graduate from therapy and sort of go on to be their own therapists. So to target some of those physical symptoms that often come along with anxiety, we'll teach youth and families emotion identification skills, mindfulness, sometimes relaxation. To target that cognitive piece where youth tend to get stuck in those thoughts about bad things that might happen, we'll work with youth to evaluate the evidence for and against some of their anxious thoughts, other strategies to have a different relationship with their anxious thinking, to sort of be able to shrink down the worry and help them think about situations in a way that's going to make it easier for them to approach rather than avoid. And then the last piece is really the key ingredient. So what makes CBT for anxiety effective is helping youth and their families step by step to face fears, to gradually try things out, even when the youth is feeling nervous. And this is called gradual exposure. Sometimes we'll also use some problem-solving skills, some distress tolerance skills to help the youth, again, practice facing fears. Next slide. And I think that exposure is so important that I made it its own slide. I think that a lot of times when youth and families are in cognitive behavioral therapy, this might be a piece that's missing. They might not actually be doing exposures as part of their sessions or between sessions. And so this is a nice thing to sort of check in with families about. Are you doing brave practices? Are you doing exposures? Is that helpful? How is that going? And the reason this is so useful is because there are a lot of very valid reasons that a youth is experiencing elevated anxiety, and avoidance is the thing that maintains it. So the youth is in a situation, they feel nervous, they avoid, that feels so much better right then and there, but then they miss out on the opportunity to learn how to handle the situation, for maybe something different to happen than what they were worried about. And so exposure therapy is helping youth and families to create and actually put into practice a step-by-step plan in a safe, supportive way to practice facing fears and be able to do some of those things they need to do and want to do, but anxiety is getting in the way of. Next slide. So on this slide, I have some quick tips for parents on what they can do to support their teens, because they really do play a pivotal role. There are two incredibly common reactions that parents have when they have an anxious youth. One is being more dismissive or frustrated. It's okay, just do it. It's no big deal. You used to do this all the time. And then the other incredibly common and understandable reaction is to feel very distressed, seeing their child in distress, and to rush in and accommodate and protect. And so both of those reactions make so much sense, and at the same time can make it harder for parents to really support their children in the way that's going to be most helpful. So this acronym CARE is just a nice way for parents to sort of have in mind some of the tips for things that they can be doing. So the C stands for being a coping model. So caregivers can be incredibly helpful for their children by modeling themselves how to identify anxiety, how to manage it, how to try things out, how to be flexible, how to go forward even when they're feeling nervous. This is different from being an expert model, just breezing through life, never feeling anxious, having no problems. It's really parents showing through their own actions how to cope effectively with anxiety. The A stands for accommodate less. So in the anxiety literature, accommodation is anything that the parents or the school or the environment is doing to help the youth sort of collude with the anxiety and prevent that youth from being able from trying things out. And that makes the distress go away in the moment, but actually leads to anxiety continuing. At the same time, when you have a child who is incredibly anxious, they might need some initial accommodation to take some steps toward facing fears. And so here we really want parents, if they're putting in an accommodation for their child's anxiety, to make sure that that is actually supporting their child and taking a step toward the thing they're feeling nervous about, as opposed to helping them escape or avoid the situation entirely. The R is reward brave behavior. This is my favorite as a CBT therapist. I love rewards. For parents, this can be praise, attention, special activities, getting out of doing chores, lots of different ways that parents can give their children credit for doing this very hard work of exposures. And then the E is to empathize and normalize. So how many times has it been helpful when somebody's told you don't be anxious? Probably not a lot. So dismissing anxiety, being frustrated or punitive doesn't tend to help. Instead, for parents, when they're able to get down on their kids' level, understand what's making them feel nervous, empathize, and at the same time, normalize. It's okay to feel this way. A lot of people feel this way. And this feeling is safe and temporary. This is a hard feeling to have, and at the same time, to also be encouraging for taking steps to face fears. Next slide.
So in addition to therapy, another treatment option to think about is medication. And some of the times to think about that are, one, if they've been doing therapy and have had limited improvement with therapy, if their anxiety is more severe, such as having like a GAD-7 of over 16, if the anxiety is so intense that the patient's unable to engage in therapies, such as doing exposures, or if there's a comorbid disorder that requires treatment. And one thing that's helpful to keep in mind is that while either alone, treatment with CBT or treatment with an SSRI is more effective for anxiety than placebo, that the combination is the most effective treatment. So the main SSRIs we think about for treating anxiety in youth are sertraline, fluoxetine, and escitalopram. And here on the table, you see the dosing guidelines. And also, I think it's helpful to note that while all of these do have FDA approval for treatment of either MDD or OCD in youth, they actually don't have FDA approval for treatment of generalized anxiety or other anxiety disorders, but they're still kind of our first line medication treatments. And a very common question that comes up is kind of where to start with in terms of anxiety medication. Sometimes if we've had a family member who's had a particularly good or bad response to an SSRI, we use that as a guideline as where to start. In terms of otherwise, with fluoxetine, that one tends to be the most activating. So sometimes is a less good option if anxiety is especially prominent, but can be a good option if there's kind of both anxiety and depression in the picture. It also has the longest half-life, so it can be a good option if there's somebody that's maybe a teen who is, has less consistency with taking their medication and tends to forget, then fluoxetine can be a good option. Sertraline and escitalopram, are both good options when there's a lot of the anxiety is more prominent and you're kind of wanting less of that activation. They're both good options to think about. All right, next slide. And then in addition to medication and CBT, the other thing you can think about is kind of psychoeducation about anxiety and resources to recommend. These are really helpful to kind of share with all your families with kids with anxiety, but there's kind of two groups in particular, I think especially emphasize it. One is in kind of that maybe sub threshold people. So you're seeing an anxious kid, they're not at the point where they're really meeting criteria for an anxiety disorder, but there's a fair amount of anxiety there, and you're worried about it kind of developing in the future. I think in that case, some of the books, especially for parents, can be really helpful to kind of help teach the parent and kid how to manage anxiety and hopefully prevent it from getting to the point of an anxiety disorder. And the other ones I especially recommend it for is, while we, in practice, often that they have anxiety, you think they would benefit from CBT. Actually getting them to see a CBT therapist is a whole nother issue, and it can be really hard sometimes to get them into treatment, and there can be long waits. So I often, in that case, really encourage the parents and kids to check out some of these books. There's also some online trainings about, for parents especially, how to manage anxiety and how to support their kids in managing anxiety that can be helpful to kind of get them started while they're waiting for therapy. And kind of after today, we'll also send you a handout that has additional kind of books for parents and kids, as well as websites and online talks for parents. And you can also check out the CAP patient resources anxiety page.
So much for this great talk. We have like maybe 2 minutes, like if anybody's got any quick questions for our speakers. Feel free to unmute yourself if a question has come up.
It's Vicky Agnost. Is there any resources to train, not to get a degree, but to train physicians or care providers to do CBT? Because I think that, obviously we don't have a lot of time in clinic, but just some training for us on the ground would be great. I think it's a skill set that it not only for anxiety, but for other parameters is very useful.
So we are actually, CAP is actually developing something. And so be on the lookout. It's a collaboration with the school-based ECHO on evidence-based practices, including CBT, kind of getting the basic kernels of behavior management training, basic principles of CBT, and then DBT for other practitioners out there. So be on the lookout.
Okay, great. I'm excited. Thank you.
Fantastic. Okay, I'm seeing other questions here. What is the youngest you can start SSRIs? I'll direct that to Lauren.
Yeah, so it ends up depending. I think in the very young kids, we really try to emphasize doing behavioral interventions, a lot of work with the parents, and kind of in terms of helping the parents manage the kids' anxiety before we think about SSRIs. We do sometimes, if kids have been doing therapy and they're still having a lot of anxiety, we'll sometimes think about them in the kind of six and older range. I think maybe 5. We don't tend to really use them younger than that. But definitely with the younger kids, try to emphasize the behavioral strategies and really working with a lot of work with parents. And I saw in the chat a question about whether they need to do EKGs before starting SSRIs. You don't. No need to do a EKG before starting. It would be more if, there's, I think, pre-existing cardiac concerns, or if they were on other medications that could potentially prolong QTC would be the kind of only times to think about it.
There's another question about ADHD and anxiety.
Yes. So the question is, if a patient has ADHD and anxiety, would you recommend a non-stimulant for ADHD and SSRI? Can an SSRI and stimulant be given together? It's a great question. So often, we'll really tend to look at what's causing the most problems and really engage kind of the family too in thinking about kind of which piece is causing the most issues right now. And we'll often try to treat that first. If the ADHD is either the more prominent or they're kind of similarly causing problems, we often start with a stimulant for ADHD first, just because it tends to act faster than an SSRI. And I know there's often concerns about whether a stimulant might worsen anxiety, but kind of at a population level, we really don't see that to be the case. And often treatment of ADHD can actually reduce anxiety because having untreated ADHD is a pretty anxiety-provoking experience. And then kind of as we're treating the ADHD, if the anxiety is still pretty significant, then we may think about adding an SSRI as well. And it is okay to give both a stimulant and SSRI. On the flip side, if it's more that there's some attention issues or maybe history of ADHD, but the anxiety is really the most prominent, then we'll sometimes start with the SSRI and then kind of see where the attention and school performance piece is at as we treat the anxiety. And if it seems like even as the anxiety improves, there's still a lot of attention challenges, then thinking about adding in the stimulant.
This to Anna, any resources for CBT in the community Central California area that you know about?
I don't have anything super off the top of my head. I think working with the school, often they'll have ideas. The company that I'm a part of is telehealth, so across the state of California. And then there are also a lot of providers that are doing tele that just really increases access, which is exciting. And I'll do a little bit of I'll look into it and send some resources out after.
Fantastic. And the last question about the concern for basically suicidal ideation and SSRIs, we will have a whole session on SSRIs, so please come to that one. And that will probably be happening not in September, but maybe October, November. Will be a specific session on SSRIs, so definitely come to that one. We'll address that one in spades. Kids who use marijuana and also on SSRI, I think it's a great question, but I think we'll reserve that question also for that talk on SSRIs. And does telehealth take Medi-Cal? I think it really depends on the telehealth company. Most of them take private insurance only. So for those with private insurance, I like to go to the Psychology Today Therapy Finder and look there. For those on Medi-Cal, you're mostly better off going through the specialty mental health system in your county. So whatever that looks like, that's basically what you have to do. And the data on using adjunctive medicines like the long-acting clonidine or propranolol for the physical symptoms of anxiety. Lauren, I'll let you take that real fast before we switch over to our case.
Yeah, I would say there's not a lot of data for either of those, especially in youth. They are both things we sometimes use as adjunctive treatment. We tend to start with the SSRIs and CBT, but if there's kind of continued challenges with both of these kind of help on the side of, if you think back to the CBT triangle of the kind of that feeling part of the fight or flight response, the thinking with both of these is to help kind of calm that kind of physical body reaction to anxiety. And they can sometimes be helpful, but there's not a lot of data in youth for their use in anxiety.
So much. So with that, we're going to switch over to our case discussion. So realizing that we are kind of near the top of the hour here, so let's go ahead and try and wrap this up. And actually, if we could go ahead and flash up the credit slide at this point, this would be great. So for people to check in, so you can get the CME credit for this hour. But to kind of wrap up this case discussion, I would love directly to hear from you, Imtiaz, if there are one or two takeaways that you have from today's discussion that are striking you at the moment.
I think, I think one good thing about this hospital is, a lot of what's been challenging with this family is some of the kind of family's belief that, because she's had a lot of somatic complaints related to anxiety. And a lot of our discussion has been like, this, not saying that this is in your head, but the anxiety is contributing to this. And I think having her being hospitalized and getting the intensive care she's getting right now, I think that's going to help make the family a little bit more amenable to trying more medication. So I think I'm going to, we'll see what she's on when she leaves the hospital, because I assume with the eating disorders clinic, a psychiatrist we're probably going to see her as well. But my idea, I think trying her on a higher dose of Zoloft, especially since mom was on it before, they might have less suspicion about that. And then just kind of, what Vicky was talking about, control is a big thing in this family because the father is a very overpowering figure in the family dynamic and tends to drown out mom and daughter. So I think being able to talk to him a little bit more, especially in light of this hospitalization and the eating disorders, that really this is how she's taken control, and we need to find healthier ways for her to do this and to back off on her weight.
Thank you so much for that wrap up here. So for those who need to leave because of clinic or other obligations this afternoon, please feel free to. Hope to see you again next September at September 13th. It's always the second Wednesday of every month from 12 to 1. Our topic will be depression. That's the subject, and with our subject matter expert will be Dr. Ritterer, who will be speaking. Let me know if you have a case to share. If you can stay for a couple more minutes, we can continue the discussion. We don't have to turn this off right away. You're welcome to go if you need to, but welcome to stay just so we can continue the discussion just a bit. Further discussion on this case and or talking about the question that had come up about how to talk about obesity in patients with eating disorders and how we kind of navigate that tricky kind of transition. So it's great to see all of you here. And for those of you who can stay, I hope you can stick on for a couple more minutes. Thank you. And then big thanks to Dr. Corey for presenting a great case for us. Thank you.
Thanks everybody for the input. Thank you.
Okay. So I'll let people jump off if they need to do this, but it looks like there's a decent number who could actually stay on. And so for those who would like to talk a little bit more, there's plenty more to talk about in this case here. If you'd like to continue talking about that, or is there a preference to maybe talk about kind of this fine line that we have to walk many times to talking about a healthy weight, but doing this in a healthy way that doesn't here I was about to use a terrible pun, feed into an eating disorder. So any preferences here as to how we use this time?
Can you hear me?
Yes.
Hi. I don't know if this is the right topic for discussion, but with the new AAP guidelines for obesity treatment, I know she has eating disorders, and she lost a lot of weight, 40 pounds, probably with all what we discussed. But at some point, when she is recovered from that point, is it something to discuss with the patient, or when with her initial BMI of 33 to offer a medication for weight loss may I don't know, advantage at that point.
This is a very tricky line. I think many of us are trying to walk here. Okay, so would love to hear other people's thoughts about, how we manage that balance here. Okay, I'm seeing this message coming in about unable to complete the link or QR code for credit. We've had a few people with this issue before, but I believe Runal will make a note of this and make sure that you get the credit. There's a back end way that we can do this. So if there are others who are having this issue, please message Runal and let her know if this is an issue for you. And yeah, okay, great. Okay,
Yeah,
with that,
I think
yes.
it's a great question. I would say this is definitely outside my area of expertise, but I'll weigh in some of my thoughts and then also really invite others in the group to join in as well. One, we've in the past, we have if you go to our website, there's a couple, I think 2 different prior webinars on eating disorders that, and I know that have addressed kind of that. A lot of questions came up around how do you manage when there's an eating disorder and concerns about obesity, and some of the very very basics I took that I kind of hold as just little basic pearls is kind of really that weight isn't a great predictor of health in and of itself, and to really focus on kind of healthy behaviors. So like shifting the conversation away from weight and trying to focus on, this is at a point where, eating disorder and recovery, kind of like just maintaining healthy eating, having family meals, healthy activity, but trying to keep it away from that weight piece and just about kind of overall kind of healthy lifestyle. And then in terms of the medication piece, I don't think you'd be thinking so much about a medication specifically to cause weight loss. I think one thing that sometimes comes up in people I see who are overweight and have ADHD is that in adults, Vyvanse in particular is a stimulant medication used for ADHD that also has FDA approval in adults for binge eating disorder. So I think that is something to sometimes think about in if you have a patient who has, I wouldn't use it if they didn't have ADHD, but if they have both ADHD and there's concerns that binge eating might be contributing to obesity, that thinking about potentially Vyvanse as something to try that may help with both. More acutely with this patient, we didn't really get to talk about it, but I wonder about like her compliance with Concerta and to what extent was being on the Concerta also exacerbating the restricting, because that's certainly that we worry about that and want to keep a close eye on that in patients with both ADHD and treated with stimulants and then eating concerns.
I'm just thinking about I'm just thinking about the pre-eating disorder conversations with families who seem to have a lot of control issues around their kids and eating, and may have some weight issues, elevated BMIs in the kids, but that there's just lots of control issues around that, and how to navigate that to best facilitate not developing eating disorders or whatever, if there is a way for that.
What I love about pediatrics is we can think preventatively, right? It's like there are early kinds of signs that something is going down. Eating and meals in this family.
Yeah, and we often see such co-occurrence between anxiety and eating disorders, and with anxiety disorders, we see a lot of parental over-involvement and over-control that can make it worse. So I think giving parents some, psychoeducation about noticing when they're having that urge to kind of step in and protect or over-control, and sort of how that might backfire and actually lead to elevated anxiety for their kid. And then the other thing I always think about is modeling, sort of how are parents talking about food and body image and things like that, and little ears have big, little pitchers have big ears or something like that. There's probably a lot that their kid is picking up that they might be aware of.
And there's kind of shared by our eating disorder team, there's a great AAP article from, let's see, it was from 2016 that talks about kind of preventing obesity and eating disorders in adolescents that we can share with you guys afterwards, that talks about some of the kind of more early kind of prevention strategies in terms of like encouraging family meals or things that we know can, discouraging parental weight talk and weight teasing. So some of the things that we know can be helpful for preventing obesity and preventing eating disorders.
Definitely send that these notes handout for today. That's an important, I think that's an interesting point about parent overprotection, over control, contributing both, right, to the anxiety and also to disordered eating. That I think is an important thing to capture here, and would love to add that to our notes as well, even for the benefit of those who couldn't stay on for this second part of the conversation.
I have a different question. It kind of moves. It's still related to anxiety, but not from eating disorders or anything like that. It has to do with like CBT and like kind of the grade exposure. Of course, the CBT is definitely like, exposure therapy, try to like, not do the avoidance and that kind of thing. But some things just by the nature of the case itself is difficult to do that. So I'm trying to figure out what is that balance. So I'll give you an example, like, a kid who's in like a very, small school, very academically challenging, but not very like social, hates going to that school, starts to develop anxiety, depression, cutting behaviors because the distress is like, I just don't like the school. I don't want to be in it. And then, they're like, well, what's better? Well, maybe let's pick a bigger school with like, a public school or something like that. And then maybe you're going to be happy. Like, at what point do you think, like, it's kind of hard, right? Because that's a major life event, or like moving or something like that. That's a major. So it's not like you could do a graded exposure to changing school. It's like, either you're going to go to this school and, and then you have that kind of thing where you're just like, well, is that the anxiety talking, or is it true? Because, you have some good points. That's, you do have some good points. Like, you aren't getting good social connections, or there aren't extracurricular activities at your small school. So I can see why you might be distressed. But is that anxiety talking? And if we move you here in a big school where you have all these opportunities, now are you going to develop some other anxiety thing, like a social anxiety thing? And then you're kind of like, do you make the, and then you start thinking, is that avoidance? Because now you're like, well, no, you should try to stay happy in this school. Does this make sense? It's kind of a very difficult balance. I don't know if anyone had thoughts on it, but yeah.
It is a difficult balance. And I think that a lot of times the anxiety is doing part of the talking, and also there might be legitimate and valid reasons. So I think inviting the family to kind of explore what are the different things that are going on, and ultimately it's going to be a family choice about what they think makes the most sense. There are, educational consultants. They can talk to, people in the school system to get a sense as well. I think what's really important, like you're sharing, is if the child does switch schools, that they're then able to engage in the new school setting. And so even if they're making this big change, it's not, I always feel so sad when I hear about youth who then do online school because they're so nervous and they completely miss out on that opportunity for learning, for socializing. I can't even count on one hand the number of times that I've seen that be helpful. Only in like very severe cases of bullying have I ever heard about that, even when there's no other option. But I think the fact that they're moving to a different school is better than no school. And then if they do change, thinking through what's the plan going to be for helping that teen to engage in school and activities and socializing.
Yeah, that's perfect. That's a great example, because exactly, like, they go to online thinking that that's the solution, but then it ends up being some weird avoidance also. Right. Okay. All right. That makes sense. Thank you.
Yeah.
The other
and
thought
I feel
about,
like,
go ahead.
I was just going to say, I feel like as pediatricians, you probably get requests a lot for, making the case for online school. So could see this coming up. It's hard to say no.
But it also seems like a great opportunity, especially like if you have somebody like a therapist to help them sort through, okay, here are all my reasons for wanting to switch, and to kind of label which of these are true, like are factually true, and then which might be my anxiety talking, right? And is there a way to find out like how much fact is behind that anxiety, right? It might be a good exercise in thinking through your thoughts, right? And evaluating your thoughts, and then making a decision based on facts rather than fear.
That's perfect. Yeah. Okay. That's great advice. Thank you. Mm-hmm.
Yeah. And one of our, in our I work for 2 different healthcare systems. And so at Contra Costa County, parents don't have the options to shop around. And so it's also kind of difficult, right? Because they can't necessarily segue their kid into a different school district, even if that might be better. For example, going from Antioch to Brentwood may have better resources, but they can't. Right. And so then it almost, for many of these parents who have limited time, limited resources, can't get in for therapy, they frequently will fall into the pattern of taking their kid out because a kid got bullied. and it's just, it's just hard because I've got very limited sort of realm to work with. And in your heart of hearts, I'm thinking the same thing, but it's like, I don't live their life, right? I don't live how hard it is to, you have to work nights and then your kids, but I get it. I think what I got out of this is that avoidance of the issue by taking the kid out of something that may be uncomfortable is not necessarily the right answer.
Yeah, and I think you do have to think about safety, and I think it doesn't necessarily have to be all or nothing, even though the anxiety might make us feel like it needs to be. So maybe there are certain classes where, they're not in PE this year because that's where the bully is and that's where they were experiencing this. So they don't take PE this year, but they're still sort of going to these other classes, and the school works with them to have a peer who's able to connect with them and go with them to certain classes. So they can start to feel more comfortable and also be less of a victim for any bullying that might be happening.
This is a fantastic discussion. Was there one last thought?
Yeah, I was just gonna throw in. I also think I think you're commenting with like going to a new school. There, it's hard to think of like how to make that graded because it's just like this all or nothing switch. And I think some things that can be helpful is even, thinking about one over the summer, like with kids that either were refusing school or have a tendency to do that. I really emphasize getting out of the house. So they may not be going over to school over the summer, but I don't want them to spend the whole summer in their room or in the house. So like, I really try to emphasize, it depends where they're at, but like trying for like, get out of the house in some way every day, whether it's like take your dog for a walk, go with, on a walk with family, go see friends, go to the store and, get a croissant or something. Just like something that keeps you in that habit of leaving the house. And then, or go to like having an activity you go to that can be a good step up to school. And then as you're getting closer, even going to visit the school. So, get in the habit first of like, okay, I'm leaving the house every day. That's going well. We're getting closer to school. Let's just go to the visit. We can, walk around outside or, and if it's a new school, also trying to like make sure they can have some orientation or tour to walk around the school itself. So there can be ways to kind of get started.
That's great. Thank you so much. These are all great thoughts. Thank you so much. It's helpful.
So we're able to stay for a little bit longer in this discussion. Do you think it's about time to like wrap things up? I'll let you guys move on with your day, but another huge thanks to Lauren, to Anna for speaking today, and for all of you for participating in such a great discussion. Thank you. Hope to see you.